Good morning, everyone. My name is Keshav. I'm one of the second year internal medicine residents at Memorial Healthcare System in South Florida. I'm excited to present this case today of a patient who presented with a massive PE and presented 8 months afterwards with strokes, possibly secondary to a persistent right to left intraatrial shunt because of development of CTEPH. So our patient was a 37-year-old female. She had a past medical history of menorrhagia due to uterine fibroids. She presented to the ED with acute hypoxemic respiratory distress as well as severe anemia. Initial echocardiogram showed a severely elevated RVSP of 92 mmHg as well as signs of right heart strain as shown by figure 1. CT angiogram of the chest revealed a massive right-sided PE. Emergent aspiration thrombectomy retrieved friable clot, which prompted us to place a catheter-directed thrombolysis approach. A pulmonary angiogram, as shown in figure 2, demonstrated severe pulmonary arterial hypertension, as well as the thrombolysis infusion catheter can be seen in situ. Over the course of next 2 or 3 days of hospitalization, patient had worsening hypoxemia, which was concerning for a possible intracardiac shunt. This time we repeated an echocardiogram with a bubble study, and it was in fact positive for right to left intraatrial shunt. Patient was started on inhaled nitric oxide and her respiratory status improved with continuous anticoagulation during the course of hospitalization. A repeat limited echocardiogram showed improvement in right-sided pressures, and she was discharged on Riociguat and low-dose apixaban due to severe anemia. She did receive an outpatient echocardiogram, however, without a bubble study. It showed complete normalization of right-sided pressures. She also received a CT angiogram of the chest, which only reported mild residual filling defects. However, her rope score was 4 and she was not really evaluated for shunt closure at that time. 8 months after her initial presentation, she presented to the ED again with slurred speech. Brain MRI this time showed multiple punctate frontal lobe strokes as seen in figure 3. A transesophageal echocardiogram with a bubble study confirmed evidence of persistent right to left shunting. This case highlights a crucial gap in the existing literature for CTEPH as well as persistent right to left intraatrial shunting. Although this patient had normalization of her right-sided pressures on echocardiogram, indicating that the CTEPH had more or less resolved or improved to an extent where it wouldn't be clinically significant. However, patient persisted to have right to left intraatrial shunting. Because of this reason, we recommend initial echocardiogram with bubble study in all patients who come with massive PE or moderate to high risk PE. In those where intracardiac shunting is found due to momentary increase in the afterload of the right side of the heart, we recommend repeat echocardiogram with bubble study within the next 3 months. If shunting persists, these patients should be evaluated for shunt closure regardless of the rope score. Figure from one of the studies is very important in our patient because it shows how persistently elevated pulmonary pressures, because in the context of chronic thromboembolism of the pulmonary vasculature, decreases the RV contractile reserve, which might have been the case in our patient who persisted to have this right to left shunting even though her pressures resolved and normalized. Thank you very much for listening to this case. Hope I was able to describe it properly. Very excited to be a part of this conference. Thank you.